So good morning to all. So as you all know, smile has been increasingly preferred as a mode of treatment for myopia and myopic astigmatism owing to its enhanced patient satisfaction, better ocular surface stability, biomechanical strength, safety, efficacy, and predictability. Smile has been US FDA approved and CE marked too. So this is the Smile 500 kHz CAR-Z system, which consists of the computer unit, laser arm, microscope, which has been integrated with different illuminating systems like diffuse, lit, and IR, and the vacuum system, the patient supporting system or the bed, which moves up, down, forward, and reverse, and a foot pedal. The important steps in the smile or any lenticular extraction would be docking, femtosecond laser application, lenticule dissection, and lenticule extraction. So as you all know, I'm talking about the 500 kHz smile or the first generation, which has a longer suction time of 25 to 28 seconds. So it is important for beginners to choose your patients properly. You should avoid choosing patients during your initial curve with difficult orbital anatomy or with uncooperative patients. Preoperative preparation becomes very important. The patient should be adequately counseled and informed consent to be obtained. Topical antibiotics to be instilled prior to surgery. Topical propafcaine 0.5% is instilled in both eyes to provide topical anesthesia, and it is also important to note that excessive instillation will cause black spots and epithelial loosening. So these are the treatment parameters which has already been elaborately explained by Sir in the previous talk. But I just want to know the cap thickness, although it ranges from 100 to 160 microns, based on the surgeon's preference is usually between 100 to 130. The incision width is planned again between 2 to 5 millimeter, which doesn't have a significant postoperative visual impact if you even keep a 5 millimeter incision width. The lenticular diameter ranges between 5 to 8, but the optical zone mostly is 6 or 6.5. The transition zone is usually for the cylinder or not for the cylinder sphere. The minimum lenticule thickness averages around 15 microns. So these are the different settings which are there, but mostly it's preferred for the expert mode for the surgeons where you have modifiable settings. The standard and fast mode doesn't have modifiable settings. In expert mode, the surgeon can modify the settings based on the patient response and the laser optimization. So this is the chart which has to be entered prior to docking. And this, if you see, the treatment pack size comes as small, medium, and large. Based on the white to white, it has to be selected. But for the Indian population, mostly we use the small size cone. So this is the treatment objective where the docking or the suction apparatus is fixed. So this is the sterile contact glass or the patient interface, whatever we say, is connected to the docking surface, and it is slightly raised for it to have the auto calibration done. The Visimax treatment pack consists as a pre-sterilized single-use disposable accessory. No cleaning, disinfection or re-sterilization is recommended. The treatment pack comes in the blister pack that has been already tested to maintain the sterility. So this is the contact glass or the patient interface. Once it's attached to the docking surface, we ensure that there is no contacting agent used with it or the liquid shouldn't enter the vacuum tube. The vacuum tube will be connected to the suction vacuum connection fixture to the other side. And we ensure that the centration as well as docking has a very short surgical time. And we also ensure the background noise in the OR is kept minimum when the eye is under suction. Once the suction apparatus is fixed or the contact glass is fixed, the patient supporting system will be moved. Before that, the vacuum system or the vacuum tube has to be connected to the connecting fissure on the laser vacuum system. And once the machine senses, the laser console senses the adequate pressure has been obtained, the ready mode activator indicates that the lights over there, which says that adequate suction has happened and now the eye is ready for the laser pass, and we press down the foot pedal continuously to have a smooth laser. So the sequence of events goes like the patient interface or the contact lens is first fixed. We connect the vacuum. The patient supporting system or the bed is moved up. The eye is applanated. The suction activated. We check for the LED indicators. Then we go ahead with the laser pass. Once the laser is completely passed, it has an automatic cutoff where the bed system moves on to a safe distance. The similar things is being repeated for the other eye. So this is just a pictorial thing where we see the centration is done, IR activated. The centration is basically done using the CSCLR or the coaxially sighted corneal light reflex, and it creates the 500 kilohertz femtosecond system creates an intrastromal lenticule pocket where the posterior surface of the lenticule is created first, which is shown in the picture B, then the anterior surface of the lenticule cut, and finally the incision cut. So these are the recommended instruments, mostly the transfused spatula, advanced lifter, and smile. So this is just an animation for us to explain about the procedure. The Sinski's hook is used to open the incision first. Then we prefer creating two pockets. I usually prefer to do the posterior pocket out to in, then the anterior pocket which goes out to in again. The posterior goes into out, the anterior out to in. The dissection should always be the anterior. We use the same plane, then we go back through the plane where we created the posterior pocket, and this we prefer doing it in the segmental sequential dissection method, where the lenticule closer to the incision is dissected last to provide the anchorage. So before docking, the speculum application becomes very important. Although the docking here is only corneal limbal suction, adequate exposure of the cornea is really needed. So we prefer using a bladed speculum like this to prevent the eyelashes coming into the treatment field. There are tapes available or a simple micropore to make the eyelashes away from the field, which is very important for us during the femtosecond laser pass. We do not want any kind of debris coming in contact with the contact glass. So that's the reason that we prefer the eyelashes to be away. So the docking is centered over the coaxially sighted corneal light reflex, nothing but the reflection of the green internal fixation light over the cornea. So once the femtosecond laser passes, you will ideally have a smooth layer of the femtosecond layer with two rings, the cap ring and the lenticular ring, and finally the incision cut. Here you can see there is an opaque bubble layer. Although the complications will be dealt in detail by the next speaker, I would just want to let you know, for beginners, it is important that you keep in mind thick corneas and thin lenticules will predispose to opaque bubble layer where you end up having difficult dissection. So this is how an OBL looks. Again, black spots are non-lasered areas due to entrapment of small air bubbles. So black spots and dry spots will again have difficulty during dissection. So these are non-lasered areas there, which will have a difficult dissection. Excess saline again should be avoided. The cornea should only be adequately moist, but you should not have excess saline, which will lead on to suction loss. So that's a case where we had excess saline, but we were fortunate enough that this case didn't experience any suction loss. So this is another case. Although the patient did not have excess saline, verbal anesthesia becomes more important more than the topical anesthesia. Some patients become really uncooperative during the laser. So you need to constantly make the patient calm and make them understand. So that's where we ended up having a suction loss during the middle of the procedure. So lenticule dissection, as I've already told you, there are two rings which helps us in which serves as a visual landmark for us to identify the plane and helps us in further dissection. So when you enter the posterior lenticule first, you'll end up having a cap lenticular adhesions. So to prevent the cap lenticular adhesions, we have different signs such as the meniscus sign, shimmer sign, and the white ring signs. All these signs helps us in identifying the correct dissection plane and to have a smooth lenticular dissection. So this is a video for us to let you know about what is the ideal lenticule dissection and extraction technique. As you see, the posterior pocket is created, but it is a small pocket. Then I've created an anterior pocket. and the dissection is done. Here, I would like to let you know about the importance of holding the eye or stabilizing the eye with a second instrument. For beginners, I would always recommend you to stabilize the globe, which helps us to have a better traction and control during the dissection time, so that the eye doesn't move away from the surgical field, and your dissection time also is decreased. So that is how the posterior lenticule dissection goes. In a segmental sequential manner, the last part is dissected out. And again, for beginners, I would recommend you to use a spatula, which will aid in complete dissection. Once the lenticule is removed, you have to place it over the cornea to check for its completeness. And the lenticule dissection, the extraction should be done again to a capsular excess method. We shouldn't forcefully extract the lenticule. You have different instruments to dissect. Depends upon the surgeon's convenience. You have different instruments. This is yet another instrument to do the dissection. The incision can be planned at 90 degrees or 120 degrees based on the patient's surgeon's convenience. Again, 2 mm or 4 mm doesn't cause a postoperative significant visual impact. Again, different techniques for us to explain when you have a cap, the lenticule which is attached to the cap. This has been described by Hamad and Fakri, where you use a Y-shaped instrument to push down the lenticule and extract it. And again, this is described by Professor Titya et al., an AIOC guided method to identify it and extract the lenticule. Apart from this, we have various other modifications in lenticular extractions, which each having its own advantages and limitations. But for beginners, I would always recommend to go with the segmental sequential dissection method. So retained lenticule becomes a big headache for us. So initially, again, as I've already told, not to use single instrument, to go with only spatula. And during the dissection, ensure that you remove the lenticule again to a capsular excess method, so that you will release the stromal adhesions and remove the lenticule in toto. In this forceful stripping and extraction of the lenticule, have had some retained lenticular fragments which was removed in the same sitting. So that's the partial lenticule which was stripped initially forcefully. Then the retained lenticule fragment which was taken in the same sitting. So beginners, please ensure that you use a spatula and lenticular excess to be done for the extraction. Cap side cut tears and incision cut tears are very possible during your initial learning curve due to excessive surgical manipulation or excessive topical installation of anesthesia, which goes on with your experience. So, but all these things can be easily managed using bandage contact lens and doesn't have a significant postoperative impact. Excessive manipulation will end up having tears. So to conclude, SMILE has been increasingly preferred because of its precision and biomechanical stability. Patient selection becomes very important to have to provide optimal visual outcome. Novice surgeons should avoid cases with low refractive powers and difficult orbital anatomy. Identification of the lenticule edge is the important step during surgery. Lenticule misdissection is one of the most common complications which is encountered intraoperatively. As majority of surgeons are still adapting to this surgical procedure, various modifications which we have explained may not be universally applicable. Thank you.
Thank you, Ramya.